Hello, everyone, and welcome to today's Lunch and Learn session. I can still see people are getting logged in and getting into the Lunch and Learn. It's fantastic to see all of you arriving this afternoon, I should say. Um, if you've not been to one of these Lunch and Learns before, you'll notice it's a different Teams format to usual. So you've got your cameras off, you've got your mics off. It leaves you free to have some food, have a cup of tea, go for a walk, whatever it is you want to do, whilst listening to the speakers we've got today. There is a way of interacting with the speakers if you haven't done before. At the top of your Teams bar, there is a Q&A button. If you click on that, you'll be able to type in any questions you've got for presenters, and that way they can either answer them by replying back to you, or we do have a Q&A section at the end of today's event where we will address some of those questions together. If you've not met me, my name's Ruth. I'm part of the Local Care Partnerships Development Team, and we do these events every now and then to bring together learning from across the city that other people might find useful, rather than doing it on locality basis like we normally do. We've got 3 sets of speakers today, showcasing their different approaches to non-clinical MDTs. Which are ways of bringing together lots of different partners from lots of different organisations to work together on caseload discussions. I'm just going to let some more people log in because I know some more people will be wanting to join us, and I can see the numbers gradually crawl up, which is great. Okay. So before we get into our speakers, I thought it'd be useful to do a bit of scene setting as to what non-clinical MDTs are, or multidisciplinary teams, and where this is coming from in the city. So first off, we always want to ask ourselves when we're developing new pieces of work, new ways of working with one another, why are we doing what we're doing? What is the purpose of working together? And the big why is to better coordinate the care of people's wider determinants of health. So we know in the clinical world there are a lot of different MDTs, or ways of case discussions, clinical case meetings. It's very common in the clinical world. But we also know that people's health isn't just clinical. We know that there is people's financial situations, people's housing situations, their mental health, their social connections, their connections to community. All these things determine people's health. So what does it look like if we try and better coordinate the wider determinants of people's health and the care surrounding that? The next thing we want to think about is the what. What are we doing to address this? So one of the ways in addressing that why, that wider purpose, is to build a responsive team around a person's needs that transcends those traditional organizational boundaries. So what does it look like when we are working together as a team based in West Leeds, a team based in the York Road area, a team based in LS 2526, a team based in someone's locality, but also across those different Leeds City Council, community sector, the primary care sector? What does that joined up team look like? And that's how we arrive at the how, which is the non-clinical multidisciplinary team case discussion. Now, this how is just one how to fit the why, to fit that wider purpose. And today we'll be showcasing some examples of what that looks like in practice. As long as it is serving that why, it's serving that purpose, then yes, this is a great thing to do. But there'll be loads of different hows happening, loads of different things happening across the city that address that why. So when we're putting together a multidisciplinary team, There's some key decisions that need to be made, some key terms of reference that need to be agreed. And again, the three examples that we've got today have got different variations on this. Now, the first thing that's really, really important to define is what is the purpose of this? What is your why? Why is this group of partners coming together? What purpose are they serving? And from that, all these different decisions will come from that. There's some things that are really open to interpretation. There's some other things where there's some kind of set options that work well for some groups and work better, and some other options work better for other groups. And the examples you'll see today have slightly different ways in which they have come up with their key decisions, come up with their terms of reference, but that's because the purpose of their meeting, the specific thing they're trying to solve, is slightly different. So, with all that scene setting in mind, I am going to bring us on to our first set of speakers. So we have Becky and Catherine from York Road PCN coming to discuss their non-clinical MDT. Abs, just by the way, I've lost control of the presentation, so if you wouldn't mind moving us on to the next slide if possible, and I will pass over to Becky and Catherine.
Hi everybody, my name's Becky. I'm the social prescriber for York Road PCN, and joining me today is
me. I'm Catherine Joyce. I'm also a social prescriber for York Road Primary Care Network.
So we've got a short presentation that I'm just going to run through, and then Catherine's going to monitor the chat. So if you have any questions as we go along, she'll happily answer those for you, and she might just pop in if I've forgotten to say anything. So we can start, Ruth, when you're ready.
Abs, are you able to move the slide deck on for us?
You have the control.
It's not letting me control it anymore, I'm afraid.
Hey, there we go. We'll have a bit of technical difficulty. So we're York Road PCN, and it's just going to be a little bit of a run through of how it kind of started for us. So we developed the non-clinical MDTs for around the past 12 months, and this kind of cropped up from LCP meetings that we'd had. So we work with different professionals from lots of different areas to bring a sort of collaborative way of working together, so we can support each other from a professional point, but also supporting the patients as well. Our meetings are done roughly on a 2-monthly schedule. We say about a 6 to 8 week. Obviously that changes throughout the summer and over the Christmas period, but we do try to get it in every 2 months, and whoever comes, and it's just nice to kind of have that chat and get together. We started our first non-clinical MDT back in January 2025, and we've just completed the 6th one in November 2025, and we're just about to start up for this year. Next slide, please. So how did we develop the non-clinical MDTs? So me and Catherine, we attend the monthly LCPs, and it kind of got us all thinking that us and the care coordinators were going to these LCPs with a lot of problems that we were facing to be able to support our patients, but also kind of lacking being able to support each other. Sometimes it's hard when you're both in the same room, you need to think outside the box a little bit. So the LCPs gave us the opportunity to link people together, to link our organisations together, and to network a little bit better. Discussions within the LCP prior to 2025 obviously saw that a lot of the meeting was maybe us trying to sort out patient problems, and maybe it wasn't the right kind of meeting for that. So that's when the non-clinical MDT was then suggested. Next slide. So who comes to these meetings? Absolutely anyone who feels that they could benefit, whether they're patient facing, whether they're more admin based, anyone that feels like they could bring across some information that could help us as professionals. So just a few examples of the definite regulars that we have at our meetings. So there's obviously me and Catherine there, who are the social prescribers. Primary care mental health come along too when they're able to. We have a dedicated housing manager who comes, and I'd say 90% of our cases are housing related, so having someone from housing really helps us. We have lots of the neighbourhood networks there, so from the third party kind of charities, they all come along. We have Lincoln Leeds, who are the social prescribing for across the city. Carers Leeds come along. We really try to get someone from social care along as well. That's obviously can be quite difficult sometimes, but when they are there, it is really good for us to have that chat with them. And then the financial inclusion team, and that is a team that I wasn't aware of prior, so it's nice to have them there. And anyone who is in that meeting and then thinks of other people that could really help us just comes along and we invite them. So I've just done a bit of a run through of how our meetings tend to run. So we ask the cases to be brought to the meeting, and that can be from anyone who is invited to the meeting. So whether they're patient-faced or not, it's absolutely fine. They can bring, say, a challenge that they've had or something that they've learned from. We try to gain consent if it's patient related from the patient, so then we can disclose names and maybe just get a little bit further information about that patient. But if it's not consented from the patient, it's absolutely fine. We just do everything anonymous, and try to keep everything as anonymised as possible, so no patient information is leaked. An individual often chairs the meeting, and then they'll either chair it and take the notes, or someone else will kindly offer to take the notes. And the chair of the meeting can change. It's completely up to kind of who's hosting. Cases are discussed, and then it's an open floor. So the person that brings the case, they discuss everything that they've either struggled with or learnt from, and then they just ask for the help of peers and colleagues. If they do anything different, if they've not thought of something. And it's a really kind of inclusive environment of you can say what you feel, and it's safe to say, you know, what you are feeling at that time, or if you have done something wrong, and be open about it. No one's going to be there to judge you, and we all just take away from it what we'd maybe do different in the next steps. We send the notes out after the meeting and all of the follow-ups and guidance that we've kind of come together, and then any follow-ups for a specific patient is always done by the person who's brought the case. So post-meeting, you know, they might decide to chat a little bit more in depth with social care or a little bit more in depth with housing, and normally when we've got that open floor of discussion, that's when those conversations will be started to, you know, like, or drop me a message, or we'll have a separate call to this. So it really does start to kind of open up the doors of conversation, which is really nice. And it's also a little bit of fun as well. We have a good laugh in our meetings, so it makes it not too serious too. Next slide. So how do we think that these meetings have shaped the work that we provide? We've built relationships with areas of the community where we were perhaps not too familiar with, or with services that we didn't really know of. I think as PCNs, we get really stuck in the boundaries of where we work because we're so boundary led, but actually there's so many wider support systems that we can tap into who are not boundary led. Willingness to engage in discussions outside of the meetings. So like I've just previously said, we always onward refer, we always have further discussions with those individuals who can really help in a certain setting. It's helped us to collaborative work with other professionals, know who to contact. You've got a guidance to go to if you are struggling with anything, and you know that you can approach all the people who go to that meeting, and there will be no judgment, and they will just be there to help you. And then kind of what I said right at the start is that realization that there's a whole host of support there that everyone can tap into. And I think it has really helped us build strong connections that we can then pass on to our colleagues as well. And it's always good to have kind of your fingers in a lot of different pies. So it does help with your working. And then finally, just a little bit more. So overall, working with the professionals who are not our day-to-day colleagues have really helped us. So again, just thinking outside the box and thinking outside of your boundary, really. And we've been managed to gain outside perspective of a new situation so that then we can look at things from a different angle. Because I think sometimes we get a bit complacent with the patients that we see, and maybe the routes we always go down, and it's just trying to navigate those different routes. So it's definitely really helped. And I think just to finally say, we have kind of moved forward now with the non-clinical MDTs, and the LCP used to help us run these, but from this year, me and Catherine are chairing the non-clinical MDTs going forward. And we all just felt it was a good point for us to take. We've run a few, and we are kind of the people that bring a lot of the patients to the meetings. So we're quite looking forward to seeing how we go with that. And I'm sure Ruth will help us along the way. But if you've got any questions, do just ask Catherine in the chat box, or at the end, and we can answer them.
Fantastic. Thank you both so much. What a great example of how a non-clinical MDT has helped you both as well. Right, we're going to move on to West Leeds Primary Care Network. So we've got Marsha, Arena, and Millie to present from there. So I'll hand over to the three of you.
Thanks, Ruth. Thank you, everyone. It's great to be here. We can probably move on to the next slide, but I'm Rena. I've got Marsha here with me. I've got Millie here with me, who's our social prescriber. I'm a pharmacist by background, and Marsha is the PCN lead pharmacist for CBD prevention. So it's been great to hear what your Road PCN have done, and it's really nice to see some of the similarities actually between what we're doing within our PCN as well. Our non-clinical MDT has been really born out of work that we're doing to support our population living with long-term conditions, and actually the cohort that we're looking at is those living with multiple long-term conditions. What we've started to do within the PCN is really design a model of care around how we're managing this population better, recognizing that they do need layers of support to be able to support them with their health and care needs. And one of the things that really came out of some of the feedback that we got from patient representatives was that actually they spend a lot of time navigating services, and actually some of the things that some of the services that are out there that are available, we weren't actually being able to offer to them. So that's where really the non-clinical MDT has come about. What you can see here is that we've got a bit of a core network team, which we class within our sort of PCN, but we tap into other sectors. So we've got our patient and our carer and care coordinators as the core team within that, and we've got an in-house clinical MDT that consists of pharmacy, nursing, and social prescribers, dietitians. It does have other clinical teams inputting into that as well. And we have our great social prescribing team who link us up with the third sector support and other community-based services that are around us. And they are also sort of integral to the non-clinical MDT. Layer 2 shows that sort of additional support that this population might need. Things like council-led services, housing, employment, community teams, mental health, which are all starting to form part of our non-clinical MDT. And what you see is in layer 3 is that real extended network that the population living with multiple long-term conditions might need and might be tapped into already. Certain specialist services, for example, diabetes services, heart failure services. So it just shows how many different touch points people might be having with different areas of the system. Next slide, please. So this is a bit of a workflow that we've used to integrate the non-clinical MDT into a wider clinical workflow. So what you can see here for this population, we've done a bit of work with the ICB to actually find our highest risk population. We use in-house clinical staff and admin staff to invite those patients in. They're then seen by our health and wellbeing coaches, which are also social prescribers, and they have a real in-depth conversation with that team about what really matters to them and go through really understanding what's going on with that person. They're then added to a care coordinator's caseload within the PCN. They have their bloods and bits and bobs done. They get seen by a pharmacist, where that pharmacist will review the medical and social needs of that person, and then they'll be seen depending upon that for a discussion appointment. But what you can see here is after the social prescriber has seen that person, we have this third sector MDT that links into our tier 1 MDT within the PCN. So any people that are seen by the social prescribers and felt that actually they could be done with discussing that with other service partners to see what other services we could offer that person to give them a real all-rounded care, and making sure that they're getting all the services and care that we could possibly support them with. They will be taken to our third sector MDT, which we run once every month at the moment as part of this program. And we are at the point now of thinking sort of beyond the sort of the end of the pilot program, which ends in April, how we will look at sustaining that because of some of the successes that Marsha and Millie will go on to explain. Next slide, please. I think that's over to you, Marsha.
Thanks, Rena. So this is just a bit more of detail around the non-clinical MDT and the development of it. So we are already looking at patients living with multiple long-term conditions and already having a clinical MDT in place within the PCN, and that clinical MDT happens bi-weekly. We have 4 slots available on our appointment ledgers for the clinical MDT. So we wanted to integrate the non-clinical MDT into this process for this piece of work. So what we then decided to do was have 2 slots in our clinical MDT to discuss patients from our multiple long-term condition cohort. And from that can feed into the non-clinical MDT, which happens once a month. We also have Millie, who's one of our social prescribers, who acts as she's a link really between our clinical PCN staff and the non-clinical MDT. So Millie can refer patients into our non-clinical MDT as she sees that their needs. And then that non-clinical MDT happens once a month. Next slide, please. So looking at some of the partners that are involved in our non-clinical MDT, we have Barker, Leeds, we have adult social care, there's a whole list there. We've got primary care mental health practitioners, Bramley Baths, Lincoln Leeds, Active Leeds. So there are we've got really good engagement across the city for our third sector partners. And I think that especially with some of these patients living with multiple long-term conditions, there is often maybe a low-lying level of anxiety around their and that is linked in with their long-term conditions. And this can be brought out in the non-clinical MDT, and we can get the help from the primary care mental health practitioners with that as well. So it's really looking at that patient holistically rather than just the traditional clinical or medical management way of looking at a patient. And we find that this brings much better holistic care for these patients. I'll pass you over to Millie.
Thanks, Marsha. Hi, everyone. So we basically run the MDT meetings pretty similar to York Road. We've only done 2 so far, but they've both been absolutely great. we run into the challenges of setting everything up, the logistics behind it with the appointments and things. But apart from that, everything else feels like it's been a success. We have had one patient of ours that we took to the non-clinical MDT, and she's actually now, she feels like she's had improvements. She's having assessment for a stair lift, and she's doing really well. So that's great. But we feel like in the future, we would like to keep this sustainability going, but we're not sure how that will look. I don't really have anything else to say. I feel like York Road have pretty much said everything I was going to say. So well done, guys.
Oh, thanks. Thank you all. I wonder, Millie, if you've got any reflections on how it's felt for you as how it's impacted your work or your connections as a social prescriber within the PCN at all.
So we feel like it's brought the PCN staff closer, because obviously there'd be times where I wouldn't necessarily be in with Marsha or have to talk to Marsha, but it's brought us all together as a team, which has been great. And we've also
found... to me now.
I can't get rid of her now. We've also found that, I don't know if this is relatable to the York Road, but we get quite a lot of frequent flyers, quite a lot of the same people in for the same kinds of thing. Whereas with this, because it's pulled people out with long-term conditions that have not known about the service, and obviously they have been advised that if they need to return to the service, that's absolutely fine. And they wasn't aware who we were. So that's been quite nice, a bit more job satisfaction.
That's great to hear. That's really, really great. And I think what this example highlights is how it can link in with your clinical pathways and that proactive care cohort, which is on a lot of PCN's minds at the moment. So that's amazing to see that example. So we'll come back to you again in the Q&A section. So I'm just going to bring you off screen and now hand over to our primary care mental health colleagues who are developing various mental health MDTs around the city. So over to yourselves.
Hi, thanks, Ruth. So I'm Ellie Smith. I am one of the Deputy Operational Managers of the Primary Care Mental Health Team, specifically based in West.
I'm Adam. I'm also a Deputy Ops Manager and I'm based in the North East.
Thanks, Adam. So I think obviously today is just to discuss about our MDTs that we are in the process of trying to get up and running across the city, really. Could I have next slide, please, Abs? Thank you. So just to start off with a little bit of an introduction to our service. So as it's been mentioned, we are popping up kind of in other LCPs and non-clinical MDTs, but we are trying to set up our own so there is a clear point of contact there. So the aim of our service is to support GPs with managing unmet mental health needs and support those patients, obviously, who have limited time in the GP appointments, with managing kind of the mental health independently in a little bit more of a proactive and helpful way. So we have quite a broad inclusion criteria. So it is classified as anyone who does have an unmet mental health need. And what that means is that there's not a service that's available for them to access support from. It often falls between kind of the Leeds Mental Wellbeing Service Talking Therapies team or NHS Talking Therapies and the Community Mental Health team. And I think another big purpose of us doing kind of striving for the PCN MDTs is because there's currently a big transformation of mental health services going on across the country, and it's definitely pulling us more in the direction of secondary care in a lot of ways. We're having a lot more joint meetings with them, so these help us kind of stay grounded to our roots in primary care. As exclusion criteria, like I say, because his inclusion criteria is very broad, is kind of social issues that the social prescribers would cover and not necessarily a mental health need. Substance and alcohol abuse to a level where they wouldn't be able to engage in a brief intervention. where an existing service exists, but there is a wait list, and that's to do with solely mental health services. We can't offer a diagnosis, so people striving for that, unfortunately, we can't give them that. And the same with prescribing medication. We don't offer the stabilisation work whilst on a waiting list for therapy in terms of formal stabilisation. And also people with cognitive impairments such as kind of dementia, brain injury, learning difficulties that would prevent them from being able to kind of engage in that brief intervention again is an area that we'd struggle to work with just because we are so brief in input. Our initial offer is kind of having what we call a helpful conversation, but it's basically just an initial contact with a patient within 15 working days. That is one of our KPIs. And then we can either signpost on from that or get them allocated for our waitlist for a brief intervention, which is when it's felt that there's no existing service to meet the patient's needs at that time. And we look at coping strategies and a bit of one-to-one work with them as well. Next slide, please, Abs. Thank you. So like I say, the aims of the kind of PCN level MDTs for primary care is ultimately to remain grounded in our primary care roots, and ensure that there's a dedicated monthly space to discuss client cases and share best practice at kind of PCN multi-service level.
I'm still checking. Yeah.
It's also to kind of facilitate and improve clinical discussions between kind of PCN services, because like we say, at times it can feel like we're very few and far between, quite distant from each other when we shouldn't be. And obviously to kind of ensure that that client focus approach is at the centre of everything we do, essentially. Next slide, please, Abs. So what we're trying to establish at the moment is, because we do have that dedicated time built in, which we're encouraging our staff that don't currently have the primary care PCN level MDT set up to reach out to kind of like the third sector ones in West Leeds that I know the practitioners attend to things. But what we're trying to strive for is a 90-minute meeting on the second Wednesday of every month where people can bring cases from the PCNs. We do have good uptake from kind of obviously our staff bringing people to discuss, but also PCNR's roles, community wellbeing connectors. I can see Lincoln Leeds has been mentioned in the Q&A part, and they're also good attenders as well. Then PCN level kind of social prescribers. And we are really hopeful for kind of some GP representation coming as well. But pretty much any other relevant service within the PCN that's based within the practices and works in quite similar ways is really helpful. We've had health and wellbeing coaches come in, and that's been really good. So yeah, that's in terms of our membership and frequency of these. Next slide, please. And I suppose looking at like kind of the outcomes and what's helpful, I think we're all, from presenting here today and listening to the York Road and the West Leeds team prior to myself and Adam, we're all striving for that same goal of improving patients' journeys through systems, increasing the awareness of PCN level services amongst kind of our staff, but also getting our name out there too. Developing those relationships and having those good positive working relationships fostered. So it's a case of picking up the phone and getting on that first name basis. Obviously sharing experience and learning, we understand because we're working it every day, that sometimes when you've got a patient that comes into surgeries and it is mental health focus, it can feel quite challenging at times to know where the direction is. So we'd like to provide obviously that advice and support there too. Improving that client risk management as well, and more localised support for them, and ultimately that knock-on effect that it then has on engagement, because it feels like patients within the GP practices have a well-rounded support network instead of referrals to separate services. Next slide, please. So we have piloted these in certain areas across the city. So we did a pilot area in East, which was BHR, so Hare Hills, Bermondsey and Richmond Hill. We also did a pilot in South, so that's LSMP and the Light PCN, and we did a pilot site in West too. We've had some really good feedback from general practice staff and practitioners from this, and this is just one of the comments that we got, that we found it really helpful. So obviously they'd felt that the PCN MDT from primary care was a useful forum to discuss complex mental health patients, and it helps to reduce the number of CMHT referrals, so bordering into that secondary care. It contributes to closer collaboration between ours roles, and it's helped improve understanding for everyone of what kind of services within the GP practices can offer, but also what we can offer within primary care, and fostered that collaborative working. So yeah, we are still in the process of getting these set up, so it's currently a little bit scatty across the city. But in terms of like the West, we've recently set up one in Woodsley Holt Park, when I was previously in South, and we've got one set up in Morley. There's one set up in Beeston and Middleton. Adam, do you know which ones are set up in East?
It's Hatch, and there is another. I'm mainly here because I've just moved areas, so it's useful for me to find out what else is going on across the other parts of the city as well. But yeah, like Ali says, they're all, there's a lot to work, like a lot of work to do and a lot to be set up. But yeah, if anyone's got any questions, just reach out.
Definitely, and I think it's really helpful to have this opportunity to, I suppose, put our faces out there. So if there is things that people come across that they feel may be helpful for our services, then we can get linked in with yourselves.
I think as well, like mental health services are confusing even for us who are working in them at times, and like if you've got a face to reach out to, hopefully that will minimize like waiting times and referrals and getting the referral to the right place. Yeah.
Thank you.
Fantastic. Thank you both. Before I bring everyone on screen for the Q&A section, there's just a couple of kind of summarizing thoughts I had when I was looking through all the slides from those three presentations, thinking about if you want to be involved with these in your areas, or if you want to develop something, the questions you need to ask, really, because we've seen three really different examples based on different purposes, slightly different things going on in the areas, mental health needs versus multiple long-term conditions, and then York Road as an open forum, what those look like. So asking yourself what already exists. There are activities like this happening throughout the city. Some of them are really informal, catch-ups, LCAN meet. There's certain community anchor meetings that happen. There's certain different touch points that people have as professionals to share information and share practice and work together on the ground. We've been mapping what we know of. So we've got a document which is noting down everything we know of. It's not going to be everything, but it might be a good start. So building on what already exists is always going to be the preferred way to go. And also asking what's going to work for our purpose and our context. But these examples, it's not about copying and pasting a formula that already exists. It's about thinking, okay, who do we need in the room? Why are we getting together? How often is going to help us achieve our purpose? All of those things. So those key decisions I talked through at the beginning. Next slide, please, Abs. We're going to have a feedback form, so there's a QR code there. We'll pop it on screen again at the end, but I'll also post a link to it in the chat. But before we get to that, I'm going to bring all our speakers on screen to go through the Q&A function. Abs, you can stop sharing your screen, and you might need to bring your screen off. Oh, fabulous. Right. Have we... Oh, I can't bring anyone else on. Adam, I've left you off. Maybe we might tag people in and out. There's loads of questions that have come through the chat.
I've been doing my best answering just as we've been going through.
Thanks,
I've
Catherine.
tried to, but I don't think I've managed all of them yet.
There was a question that came up on the West Leeds presentation. Siobhan's asking, in one of the slides there was a to be defined around mental health, and just wondering if that could be elaborated on at all.
Yeah, absolutely. So like I mentioned, we're trialing this non-clinical MDT for a specific cohort of patients linked to a wider program of work. And so we're looking at working age adults between the ages of 18 to 65 who also have multiple long-term conditions and have some level of mental health. And the reason it says to be defined is because it's not always coded very well in systems. It's not very clear what that mental health need might be. And that's partly due to the fact that people haven't had that conversation with them because we're so bothered about concentrating on their long-term conditions. And just by the very nature of having 1, 2, or 3 long-term conditions, it can be quite a stressful, anxiety-related problem when it comes to people living with multiple long-term conditions. So when we put to be defined, it's because we've not really had a specific criteria around it. And that's been for various reasons. But obviously, post-April, and when we look at how we think about the non-clinical MDT outside of just this particular cohort, we will obviously consider those sorts of things as well.
Thanks, Rena. Question that, yes, Catherine, you did get to. Are Leeds City Council ward councillors for the LCP area invited to these non-clinical MDTs? I think Catherine responded that you've had one at one of your non-clinical meetings.
I think that we have. I could be wrong. I might just be getting confused with the LCP meetings because I know that we have, for example, I know that Helen, one of the Temple and Newsham councillors, has come along to the LCPs. A few of the councillors are quite involved with that. I think, I want to say Helen may have come to one of our MDTs before, but regardless, like, they would be very much welcome because the approach to the non-clinical MDT is very much share the love, share the knowledge, so they will have intelligence and things that maybe we don't have, and we kind of just want to get together and put all of our knowledge together. So it's something where their input would be really helpful if they had anything to share with us.
Fab. This might be getting into the territory of with different ones and different purposes, whether that would fit right. So I'm just wondering if there's any other points of view from West Leeds or primary care mental health.
I don't think we've had any counsellors that are to non-clinical MDTs that we've had so far. We definitely have them attend the LCP meetings. I guess for us, we keep our non-clinical MDTs completely anonymous, so we don't share patient details. We obviously get consent to be able to discuss their case at the non-clinical MDT, but we don't share any patient details, so everything is anonymous. So there'd be no reason why they couldn't attend and be involved in the discussions. And as Catherine said, there might be some useful information that they can share from their perspective as well.
Fantastic, thank you. So, is there, from Diane here, is there an existing forum where initiatives can be proposed and discussed that focus on improving outcomes for the target patient groups rather than individuals? For example, a space to explore ideas such as a community liver health checks run by secondary care team. Would it be the non-clinical MDT? And both Catherine and Kim from my team as well have answered, which I think is right. That's the main LCP. Come along to our main LCP to discuss those things that we discuss, ways of working together all the time, and the non-clinical MDT is just one of those ways in which we do that. Another question for West Leeds, the West Leeds team here from Julia. I'm sure all of these must have come up. I must be on the timestamp when you were all presenting. I noticed there were no neighbourhood networks in the West team. Is this because they haven't been invited, or because they've chosen not to take part, or maybe you're focusing on it younger people? And I can see, Rena, that you've answered this. Did you want to expand
the
at all?
cohort that we're focusing on. I guess we were very much working with your team, Ruth, when it came to how we develop that sort of non-clinical MDT, and there might well be, you know, partners that we've missed off there. We just started from somewhere, didn't we, really?
Mm-hmm.
Yeah, I don't know. Millie, do you know?
All the patients that we have kind of been working with have not really needed the neighbourhood input at the moment, because they're all of working age, and some of them are in work, and some of them are seeking work, and some of them are volunteering. So we've not really felt the need for the neighbourhood team at the minute. But obviously this is just in this project. In the future, that probably is something that we would be interested in, because our district has got quite a lot of elderly. So
fantastic. I believe one of the neighbourhood networks was mentioned in one of the discussions from other third sector partners, and I think that's something that once you have this group of people talking about this case as a group project, that then opens up a whole nother set of connections that maybe aren't in the room, but those people have the connections, which is fantastic. I'm trying to move through the questions that you've typed answers to, because a lot of you have been typing away, and this is the great thing about having so many presenters, is we can cover a lot of bases. Sue Wilkinson says, hi, great presentation. Do you have a plan to cover all areas within the city? I suppose this one might be more for me, and maybe the primary care mental health team as well. So I'm going to
throw me out. Throw me out.
Right, how do I do that? When it comes to covering all areas of the city, I think, again, it comes back to the question of, is this the right thing for this group of professionals to achieve that goal? So I had a conversation a couple of weeks ago with some people who were trying to get something like this off the ground in their area, but they were feeling like they already had ways of communicating with one another, and maybe a case discussion every month wasn't, like, people were struggling to engage with it because they felt like they'd already had all those connections there. So they were feeling like they could already navigate all that stuff. So it was really difficult to get it off the ground. So that's where you've got to question, is this the best approach? Now, what we're seeing today is this is a really great approach for certain purposes, but it's got to really, really stick to that purpose. And I guess across the city, what we want to roll out is better coordinated care for both people's clinical and non-clinical needs, and this is just one approach to it. That's what I would say on the LCP development side. But Ellie and Adam, I know you've got plans for the mental health coordination.
I did actually just reply to that one and just say, yeah, from a primary care perspective, like, the plan would be to cover all areas. It's just a case of doing the work and putting them all together.
Yeah, definitely. I think obviously we're keen to get them rolled out. Sometimes it's knowing who to contact, and Ruth has been a massive help in kind of linking us in with people, and getting those kind of set up and well established. So obviously there's, across the kind of ops team, there's 6 of us. that are trying to link it in alongside the other work streams and things, but this is definitely a priority for us at the moment. So if there is, I think I've replied to one of the comments and popped my email in there, but if Ruth's happy to share it after as well with attendees, or however that's shared on this format, then yeah, I'm happy for any kind of queries surrounding areas and getting linked in with that from a primary care perspective to be sent over to.
Fantastic. Thank you both. Yes, we did get a queries asking if we could share presenters' emails afterwards, and you can let me know outside of this if that's not okay for me to share with the slides and whatnot. Is there an MDT meeting set up in Bermatoffs and Richmond Hill PCN, Ruth? We have lots of forums in the area, so I could see this would be beneficial. I know that the community anchors for Bermatoffs and Richmond Hill have a weekly patch meeting where they will compare notes and developments of what's happening in the area, and there might be some light case discussion in that, and they're really open to having lots of people and opening up their doors to lots of different professions going to that. So they're open to that, seeing that develop. Chetna, I can link you in specifically with those people I've spoken to after today. But thank you for the question. James, hi there. My name is James and I'm representing employment and skills in Leeds City Council. Just wondered if any of our reps are involved, and if not, whether that would be useful resource allowing. Anyone want to come in on employment and skills?
We don't have them in ours, but we know them and we're referring all the time to them. But they can definitely come along to ours if they want. But we are fully aware. We work quite closely with them at another event that we do, so we're fully aware of them, but they can come along whenever they like if they would like to.
We do have them involved in West Leeds PCN, and it goes back to, because of the cohort that we're looking at working age adults and with multiple long-term conditions with a view to supporting them that might be out of work. Sorry, I should have added that. With a view to supporting them to either get back to work or be more ready to get back to daily activities, or which might be going back to work. So yeah, we definitely do have employment and skills support.
I think from a primary care perspective, I don't think we do have that representation from the Leeds City Council, just as we have as own employment advisors within the service. But I do think it'd be really helpful, because obviously we do have a lot of people that are needing support of kind of adult social care and wider council services as well, just to kind of have that awareness of that. And also, again, similar to what Rena said, a lot of the people that we're working with are out of work, or keen to get back in to develop those skills. So yeah, that'd be helpful for us.
Fantastic. Julie says, AGK Leeds would welcome invites to the non-clinical MDTs. We could work with any PCN across the city and provide input for people aged 50 plus, which is fantastic to know, because a lot of PCNs will be looking at people at risk of falls or with mild to moderate frailty in some of their proactive work. So that's really good to know. Does anyone want to come in and comment on that at all?
Yeah, not to sound like a broken record, but I think that'd be really helpful for us as well, because we do have a little bit of a sticking point. Obviously, our remit within primary care in terms of age is 17 plus. So it does expand, obviously, that to working age adults, but also a little bit beyond too. So I definitely think having some Age UK, and I know that we can be, in a good way, little buggers for referring in and for kind of signposting. So if we could get more of a supported approach for patients in accessing Age UK, that would be fantastic.
I think just to add as well, for primary care MDTs, it's kind of more the merrier because it's relevant to everybody. You know, like anyone can refer in with regards to mental health. So I know there's an ask on everyone's time, you know, for loads of meetings and stuff. But yeah, I wouldn't think there was many services that we wouldn't be happy to have along.
I think you raise a really good point there, Adam, where a lot of this is taking up meeting time in people's diaries, but the benefit that then has on not only the case you're discussing, but all the other cases that you come across in the future, and making those joins smoother across the system is going to save time in the long run, isn't it? But absolutely appreciative of people's capacity. So from Fiona, this has been really insightful. Thank you. Great to hear about the wonderful work going on citywide. I am Wetherby based, and we're starting to focus on proactive care in patients with severe frailty. I would appreciate any links or contacts to similar MDTs or services within Wetherby PCN, if possible. Well, Fiona, you've got one just there in the chat with Age UK Leeds. Who might be a good link for you. But also, this is where your local care partnership meeting will come in. We can support with finding those connections you need, also having discussions at LCP meetings, but also just making sure that you're set up with all the contacts that you need to get started. So yeah, absolutely. I think it's Rachel Ainscoe that usually runs the Wetherby meetings. So that'd be great to have a look at that. From Shauna, as a team manager's perspective from adult social care, I don't think we are part of any of the primary mental health work. Often the crossover between us and mental health is vital. So I'd welcome a chat outside this forum with primary care mental health. Ellie, I can see you've responded to that. So fantastic. Yeah. There's also a request further down from Mindwell to have some conversations as well, so we must link up there. Kate, there are gaps in the evidence for non-clinical MDTs. Are you currently collecting any routine data on outcomes that would be helpful for an evaluation? For example, patient feedback, clinical or non-clinical. Does anyone want to come in on this in terms of individual approaches to this?
It's a tricky one because patients don't actually attend the MDTs. They're cases that are discussed without the patient actually being there, but we do get consent from them to discuss their cases. But what we are doing as part of the program we're running is to get some sort of patient stories and feedback of the whole service as a whole. So it'd be hard to understand whether it's the non-clinical MDT that's helped deliver some of those outcomes. But I think that's it. This is just one tool in our armory of tools that we can use to support people better. And maybe that's why there's gaps in evidence, because it's not just one thing that helps people. I don't know if anyone's got anything else to add, but I know that we're not collecting any specific patient feedback about the non-clinical MDT because they might not even know that they've been discussed at that MDT.
Becky?
We're doing the same in terms of not really collecting it from patient feedback, but we are collecting it in a sense of, well, we found out Ruth's massive spreadsheet she's got that she keeps for the notes tracking from our non-clinical MDTs that we're going to take over, and it's quite useful to see that it says like the route of conversation, I guess, that we've had, so what we've come in with and then what we've left knowing. So as I know that that's not patient feedback, but it kind of does show a route of how that MDT is shaped then the next step of care for that patient, and then anything that is on those notes is reflected into the patient notes. So I feel like that's the way that we track it at the moment, and it's quite a good visual to see, as well as like the number of cases we've discussed.
Yeah, I'd say pretty kind of similar from a perspective on primary care end, because we're quite new into it as well. Well, we're newly getting these set up. And obviously patients don't attend like the other two that have been discussed. It is a case of gathering feedback. We did do a bit of an evaluation survey in the pilot sites that were mentioned in my presentation surrounding primary care, and I think we intend to kind of keep that going. I think the difficulty sometimes in us tracking kind of patient journey, so to speak, is because we are technically under the Leeds Mental Wellbeing Service, but based within GP practices. So it's not always a clear systems guide, and the systems don't always talk to each other. But it's something that we're definitely kind of going to look into going forward as we get more established.
Thank you all. I can see other questions and comments have come in the chat, but we simply do not have time to cover them. That's been fantastic. And thank you to all our presenters today. And thank you to everyone in the Q&A who has been so enthusiastic and asked so many wonderful questions. I'm going to leave everyone with the QR code on the screen to feed back. Let me just double check I've done that right. And we will be sharing the recording on YouTube, so please do share it with colleagues that might find it useful. Thank you all for spending your lunch with us, and have a great rest of your day.